Msrysy and Asia here. In this video, I'm going to demonstrate the basic projection from skull to toe. So let's start. This is the chest projection. Chest projection, we have two basic projection, which is the PA and the lateral. So this one is the PA projection. Patient must be erect, feet spread slightly, aligned with sagittal plane with CR. Then ensure that no rotation of thorax. CR is perpendicular to IR, center to mid-sagittal plane at level of T7. So this one is the lateral projection of chest. So patient erect through left side against to IR. Then position the patient through lateral with arms raised above on their head. Then CR is perpendicular directed to mid-thorax at level of anterior and posterior oblique position, cervical spine, patient position, erect position, it might be also erect or recumbent position. So part position, align mid sagittal plane to CR, then rotate body and head into 45 oblique position. CR for anterior oblique, direct CR 15 degree caudal to C4, level of upper marginal thyroid cartilage. Then CR for posterior oblique, direct CR 15 degrees cephalad to C4, center IR to CR. Lateral position for cervical spine. Patient is erect lateral, then align mid coronal plane to CR, then ask patient to relax and down the shoulder. Then CR is perpendicular to IR, directed CR horizontal to C4. Open mouth projection, C1 and C2 cervical spine. Patient position, supine or erect. Part position, align mid-sagittal plane to central ray or midline of the table. Then ensure that mouth is wide open. Then CR is perpendicular to IR. Direct CR through center of open mouth. Then center IR to CR. Shoulder projection, we have two basic rotation, which is the AP projection external rotation and the AP projection internal rotation. So this one is the AP projection external rotation. Patient is erect position. Usually this position is less painful in patient. So part position, abduct arm slightly and externally rotate arm with hands supinated. So CR perpendicular to IR, directed to 1 inch inferior into the coracoid. This one is the AP projection internal rotation lateral. So they have same patient position, patient CR, but the difference is the part position. Internally rotate arm with hand prone, then CR perpendicular to IR, directed to 1 inch inferior into coracoid process. So humerus projection, we have three basic routine, which is the AP projection, the AP rotational lateral, and the horizontal beam lateral. So this one is the AP projection humerus. So patient position must be erect, then part position, abduct arm slightly with hands supinated, then CR is perpendicular to IR, directed to midpoint of humerus. So this one is the rotational lateral or lateral medial for humerus. Patient is erect, elbow flexed partially, then arm internally, rotate arm internally, epicondyle must be perpendicular to IR. So CR is perpendicular to IR, centered to midpoint of humerus. So in thoracic vertebrae spine, we have the AP and the lateral, and this one is the AP projection. So patient position is supine or upright, then MS speed perpendicular to IR, hips and knee flex to reduce kyphosis, place support the under knees. So CR is perpendicular to IR, direct CR to T7 below jugular notch. Lateral projection, thoracic spine. Patient position, it might be lateral recumbent or erect position. So part position, raise patient arm to the right angle to body with elbow flex. Ensure that no rotation of shoulders or pelvis axis. So CR is perpendicular to IR, CR perpendicular to long axis of thoracic spine, direct CR to T7 below the jugular notch. So in lumbar spine, I'm going to do the AP or PA projection and the lateral projection. So this one is the AP projection lumbar. Patient position is supine. Part position, align mid-sagittal plane to CR and midline of the table. Flex knee and hips to reduce lordotic curvature. Ensure no rotation of thorax or pelvis. Then CR perpendicular to IR. So for larger IR, direct CR to level up iliac crest L4 to L5. For smaller IR, direct CR to level of L3. Lateral projection, lumbar spine. Patient position is lateral position. Part position, align mid-coronal plane to CR and midline of the table. Ensure no rotation of thorax or pelvis. CR perpendicular to IR. For larger IR, center to level of iliac crest L4 to L5, while the smaller IR, center to L2 to L3 at the level of lowest costal margin. So this one's the AP axial sacrum projection. Patient's position must be supine. Then part position, align mid-sagittal plane to CR and midline of the table. Ensure no rotation of the pelvis axis. So CR, angle CR 15 degrees cephalad, direct CR to 2 inches superior to pubic symphysis. Center IR to CR. Suspend respiration. AP axial coccyx projection. This one is the same of the sacrum position, but they have different CR. Then the CR, angle CR 10 degree caudal, direct CR to 2 inches superior to symphysis pubic. Then respiration is suspend. Lateral sacrum and coccyx position. So patient position is lateral position. Part position, align long axis of sacrum and coccyx to CR and midline of the table. Then ensure that no rotation of thorax or pelvis. Then CR is perpendicular to IR, direct CR 3 to 4 inches posterior to ASIS. Respiration is suspend. AP projection hip. Patient's position is supine. ASIS equidistant from table. Foot and leg rotated medially 15 to 20 degree. Place femoral neck parallel to IR. CR is perpendicular to IR, directed to femoral neck. So in pelvis projection, we have the AP pelvis and the lateral pelvis. So this one is the AP pelvis projection. So patient position, patient must be supine position. Place arm at side of across superior chest. Then part position, align mid-sagittal plane of patient to center line of table and CR. Then separate legs and feet, then internally rotate long axis of feet and lower limb about 15 to 20 degree. So CR is perpendicular to IR, directed to midway between level of ASIS and the symphysis pubis. This is approximately 2 inches inferior to level of ASIS, center IR to CR. So this one is the AP bilateral frog leg projection pelvis, rather not a lateral. So, patient position, patient supine, then provide pillow for head and arms. Then part position, align patient to midline of table and IR and to CR. Ensure pelvis is not rotated. Then place the plantar surface of feet together and abduct both femora 40 degree to 45 degree from vertical. Ensure that both femora are abducted the same amount and that pelvis is not rotated. So, CR is perpendicular to IR, directed to a point 3 inches below level of ASIS or symphysis pubis. So, in femur projection, we have AP and the lateral projection. This one is the AP projection femur. So, patient position is supine. For distal femur, leg rotate 5 degree inward. Place limb in true anatomic position. So, for proximal femur, leg rotate 10 to 15 degree inward. Place femoral neck in profile. So, CR is perpendicular to IR, directed to mid femur. Lateral medial lateral projection femur. Patient position, place patient in lateral recumbent position with affected side down. Part position, flex affected knee about 45 degree and align femur to midline of the table. CR is perpendicular to femur and CR directed to midpoint of IR. So this one is the AP projection knee. Patient position, patient in supine position, femoral epicondyle parallel to IR, leg 5 degree inward, then CR, align CR parallel to articular facet or tibial plateau for average size patient. So CR is perpendicular to IR, directed CR to a point 1/2 inch distal to apex of patella. Lateral medial lateral projection knee. Patient position. This position may be taken as horizontal beam lateral or in the lateral recumbent position. So part position, adjust rotation of the body and leg until knee in true lateral position. Flex knee 20 to 30 degree for lateral recumbent projection. Then CR, angle CR 5 to 7 cephalad for lateral recumbent projection. Then direct CR to a point 1 inch distal to medial epicondyle. Leg projection, we have the AP and the lateral projection. This one is the AP projection. So patient position, place patient in supine position with leg should be fully extended. Then part position, femoral condyle parallel to IR, foot in vertical position. So CR is perpendicular to IR, directed to midpoint of elbow. Lateral medial lateral projection leg. Patient position, place patient in the lateral recumbent position, injured side down. The opposite leg may be placed behind the affected leg and support with a pillow. Then part position, ensure that leg is in true lateral position. So CR is perpendicular to IR, directed to midpoint of leg. So in ankle projection, we have the 3 basic routine, which is the AP mortis, and the lateral. So this one is the AP projection ankle. Patient position, place patient in supine. Legs should be fully extended. Heart position, adjust the foot and ankle for a true AP projection. So CR perpendicular to IR directed to a point midway between malleoli. AP mortis projection, medial rotation ankle. Part position, internally rotate entire leg and foot about 15 to 20 degree until intermalleolar line is parallel to IR. CR is perpendicular to IR, directed to midway between malleoli. Lateral mediolateral projection ankle. Patient position, patient in the lateral recumbent position, affected side down, then flex knee of affected limb about 45 degree. So, part position, leg and foot in true lateral position. So, CR is perpendicular to IR directed to medial malleoli. So in foot projection, we have three basic projection, which is the AP, the oblique, and the lateral projection foot. So this one is the AP projection. So patient and part position, place patient in supine, provide the pillow for patient head, then flex knee and place plantar surface against IR. So CR, angle CR 10 degree posteriorly toward heel with CR perpendicular to metatarsal. Direct CR to base of third metatarsal. Elbow projection, we have two basic projection, which is the AP projection and the lateral projection. So this one is the AP projection. So patient position, sit patient at the end of the table with elbow fully extended. Part position, elbow extended, hands supinated, patient lean laterally, humeral epicondyle and anterior surface of elbow parallel to IR. So CR is perpendicular to IR, directed to mid elbow joint. Lateral projection elbow. Part position, elbow flex 90 degree, elbow flex 30 to 35 degree for suspected elbow injury. Hand in lateral position, humeral epicondyle perpendicular to IR. So CR is perpendicular to IR, directed to mid elbow joint. Forearm projection, we have two basic projection, which is the AP projection and the lateral projection. So this one is the AP projection. So patient position, sit patient at the end of the table with hand and arm fully extended. Part position, hands supinated, patient lean laterally, then humeral epicondyles parallel to IR. So CR is perpendicular to IR, directed to mid shaft or mid forearm. So this one is the lateral projection forearm. So part position, elbow flex 90 degree, forearm and hand in true lateral, thumb must be up, humeral epicondyle perpendicular to IR. So CR is perpendicular to IR, directed to mid shaft of mid forearm. Wrist projection, we have three basic projection, which is the PA oblique, and the lateral. So this one is the PA projection. So patient position, sit patient at the end of the table with elbow flex 90 degree. So part position, hand slightly arch, place wrist in close contact with IR. Yan. Then CR perpendicular to IR directed to mid-carpal area. PA oblique projection wrist. Part position, palmar surface against IR, hand pronated and rotate 45 laterally, wrist ulnar deviation for scaphoid only. So CR perpendicular to IR directed to mid-carpal area. So for hand projection, we have the PA projection, the PA oblique projection, and the lateral projection. So this one is the PA projection. So patient position, sit patient at the end of the table with elbow flex about 90 degree and hand and forearm resting on table. Part position, pronate hand with palm surface in contact with IR. Align long axis of hand and forearm with long axis of IR. Center hand and wrist to IR. So CR perpendicular to IR directed to third MCP joint. Fan lateral or lateral medial projection hands. Patient position, sit patient at the end of the table with elbow flex above 90 degree and hand and forearm resting on the table. Align apart position, rotate hand and wrist into lateral position with thumb side up. Spread finger and thumb into fan position. Then CR's perpendicular to IR directed to second MCP joint. Oblique projection hand. Patient position, sit patient at the end of the table with elbow flex above 90 degree. Part position, pronate hand on IR, central line long axis and up hand with long axis of IR. Rotate, enter hand and wrist laterally 45 degree and support it under the palm. CR perpendicular to IR directed to third MCP joint. In skull series, we have the AP axial tone method, the lateral, the PA 15 degree Caldwell method, and the PA 0 degree. So this one is the AP axial projection or tone method. Patient position must be erect or supine. Part position, OML perpendicular to IR. Align IOML perpendicular to IR. Ensure that no head rotation or tilt exists. Then CR, angle CR, 30 degree caudad to OML or 37 caudad to IOML. Center at MSP 2 to 1/2 inches above the glabella to pass through the foramen magnum at the level of the base of occiput. Lateral projection, skull. So patient position, it might be erect or recumbent semi-prone position. Part position, true lateral position, head in true lateral position. Align MSP parallel to IR, no rotation or tilt. Align IPL perpendicular to IR. Align IOML perpendicular to front edge of IR. So CR's perpendicular to IR. Center to a point 2 inches superior to EMA or halfway between the glabella and the inion for other types of skull morphologies. PA axial projection, skull or Caldwell method. Patient position must be erect or prone. Then part position, align MSP perpendicular to midline of the grid or table. Align OML perpendicular to IR. Then prevent head rotation or tilt. CR, angle CR, 15 degree caudad and center to exit of nation. PA projection, skull or 0 degree CR. Patient position is erect or prone. Part position, align OML perpendicular to IR. Align MSP perpendicular to midline of the table. Then CR is perpendicular to IR, parallel to OML, and is centered to exit of glabella.